Hello, everyone. Dr. Callahan will be here in just a minute.
Okay.
Good afternoon, everyone. Thanks for logging into our webinar here. I have, hopefully you can hear me okay. We are going to talk about alternatives to total knee replacement. And I have Kelly, she's one of our great marketing people and overall everything person to help us out with things. So she's going to keep me on track. If there's something that comes on, hopefully some audio things or any kind of audio visual issues or problems we're having, she can kind of give me a ring or something to make sure that we have everything. I think we've smoothed out a few of the kinks we've had in the past. So sounds like we're doing okay. So what we'll do is I'll be sharing my screen here. A couple housekeeping issues. I wanted to make sure that just, if you're not familiar with the Zoom functions, try to make sure that you're on mute this entire time. You should. Everybody is defaulted that way, but sometimes we can find a way. Can do an end around on our webinar settings, but sometimes people can do that, and it can we can hear other things going on in the background. And if your video is on, just kind of be mindful of the fact that your video could be showing some things that you may not wish to show. So you can always turn your camera off. And when there will be a section that will be available to us that will show for questions. So I'll open that up and we can type it into the chat box, and we'll have Kelly kind of help us out with that as well when we get towards the end. But there will be a section for questions. So please just write down your questions and we can go through the lecture, and I'll be happy to answer them. Also, a consultation in office is also available. We can set up a more formal consultation to answer any your questions, especially burning ones that are more specific. So with that, I'm going to go ahead and pull up our lecture here. All right. So, again, welcome and thank you so much for your time this afternoon and attention. I'm Nicholas Callahan. I'm an orthopedic surgeon and hip and knee replacement specialist. I'm the founder and director of the Cleveland Hip and Knee Institute. The disclosures for this talk, I have no relevant financial conflicts of interest or disclosures. Another disclaimer is we kind of mentioned and teased before, this is a general overview talk. So I'm going to discuss different treatments of knee arthritis and what it is and some of the anatomy, but it's not a time to ask your personal questions. So both from a privacy perspective, as well as being able to get down and give you a very good answer, that's usually better done in an office setting. So please don't refer to any specific questions. Generalized questions are okay though. And throughout this talk, there'll be a number at the bottom of the screen that you can call and we can set up an appointment or consultation. I'd be happy to do so. With that, I'd like to first acknowledge, using and paraphrasing Sir Isaac Newton, that I think it's important to recognize where I come from in my training and the background. And if I've ever done anything, I'd like to make sure that I recognize the people who helped get me there. And with Isaac Newton, his classic quotation as regards to that he could see further by standing on the shoulders of the giants that came before him. And those giants for me are Ryan, Molly, and Phil Frendeck. They showed me how to be a great surgeon, but also a great person and a great clinician. And I'm very grateful to them. So I'd like to give a special thanks. And then also just a little background of me. I grew up in Northeast Ohio. I went to Baldwin Wallace College in Berea, and then medical school at Lake Erie College of Osteopathic Medicine in Western Pennsylvania, and as well as did a fellowship in hip and knee replacement surgery, specializing in minimally invasive techniques. And that was done with Ryan, Molly, and Phil Frendeck there in Western Pennsylvania. So why do I do this? Why am I spending time this afternoon talking to you about this? Well, first off, I love it. I enjoy this. This is my passion. It's what gets me excited. Seeing people and being able to help people just like you, it really is what I went into medicine for. And this is a great way to interact with people and to, bring attention to things that maybe you're not aware of, or maybe you haven't heard of, or maybe you've heard on the side or from other people, but to kind of bring that education component to it. And we're constantly improving our techniques over time, and it's nice to be able to share that information with people. So our course for today, kind of general, looking at our curriculum for today, is we're going to review some knee anatomy. We're going to talk about arthritis, what our different treatments are, what's some of these alternatives to total knee replacement, what is a partial versus a total knee replacement, and how do I know when it's time for me to have surgery? So first, we have to kind of know the basics about a knee and what is it and how does it work and what does it look like. Well, the knee anatomy is composed of three main bones. There's the femur bone, which is part of your thigh, the shin bone, which is called the tibia, and your kneecap, which is called the patella. All three of those bones form the knee joint. And with that, on those bone surfaces where they meet each other and touch, there's a substance called cartilage, and it's very slippery and firm, and it doesn't have any nerve endings in it. And so this can allow you to bend and straighten your knee. And before you have any kind of symptoms of any arthritis, you may not even feel it or notice it. You kind of take it for granted. There's also ligaments that are in the inside of the knee and the outside of the knee, and muscles and tendons that surround the knee and help it move and support it. And so the knee, we kind of think of it as just being this hinge joint, but really it's so much more than that. The motion of the knee is more than just bending and straightening. It bends and straightens, as we all know, but it also moves side to side and tilts that way. It compresses and distracts, it slides, and it rotates. So there's much more motion and more function to a knee than we really do give it credit for by calling it a hinge. And so that's important to remember when we go to talk about treatments of the knee, especially any surgical treatments, to remember that concept, that it's a little bit more important. It's more involved than just a straight hinge. So what's arthritis? Well, arthritis is when that cartilage, that firm, slippery substance that allows you to move your joint before having arthritis without any pain or really noticing it all, that starts to break down and wear away over time. And when that happens, that can become more painful. And why is that? Well, the nerve endings in the end of the bones are very, very, very sensitive. And there's many of them throughout the bone. The cartilage doesn't have nerve endings, so that's why you don't feel it. Well, when that cartilage wears away, that bone gets exposed. And when that gets exposed, it starts touching the other bone, and that becomes very painful because those nerves are very sensitive to that kind of contact. So if you heard of bone-on-bone arthritis, that's what we're talking about, is that there's no more cartilage in that knee or hip, and the bones are starting to contact each other. And so here is an example of a couple x-rays of a knee that shows you on the left, the knee has perfect joint cartilage. There's good spacing there. There's no changes within the bone. That's a normal, healthy knee. If you look to the right image, you can see that that space is completely narrowed down. The bones are touching. There's bone spurs on both sides of that knee. And in that joint space, it's a little bit more white, and there's some changes within the bone that's saying that that's being irritated, and that can be signs of an unhealthy joint. So how does that happen? Well, the most common cause of arthritis is wear and tear. So over time, the cartilage starts to soften and break apart, and then as it breaks apart, it wears away. And sort of like tread on a tire, as you kind of move around more, it starts to wear and wear and wear away. Some people that runs in families, and other people's it happens from a mechanism we're not really sure why. Inflammatory arthritis is another type. If you have gout or pseudo-gout or rheumatoid arthritis, there's several other types of conditions that can cause inflammation where the body rushes a bunch of inflammatory things into the knee or the hip, and it causes the joint to wear away, that cartilage to wear away, soften and crack and break apart. It also can happen if you've had an injury. So if you fractured a bone or in the joint space, it can damage the cartilage, and that can cause that cartilage to wear away. So how do I know if I have arthritis? Well, symptoms are including but not limited to pain, there's stiffness, you might have some swelling, you might notice some range of motion issues, so you can't bend or straighten that knee as much. You might have a hard time getting up and out of a car or going up and down a set of stairs without having some pain. Sometimes it's dull, achy, sometimes it's sharp. It can be worse in the morning where you're real stiff, and then it kind of loosens up in the afternoon, and then in the evening it can ache and swell. Those are all general symptoms of arthritis. So when you have all that, what can you do about that? Well, the treatments of arthritis are kind of two camps. So there's non-operative treatment or non-surgical treatment and surgical treatment. So in the non-surgical treatment, there's medications, there's injections, there's physical therapy or exercise, and there's some different lifestyle modifications. So for the medication wise, Tylenol or acetaminophen is a medication that can be used for arthritis. There's prescription strength or arthritis strength that is available over the counter. There's other over the counter anti-inflammatories or non-steroidal anti-inflammatories, which is what an NSAID means. And those examples include ibuprofen, naproxen. There's prescription ones called meloxicam or Celebrex. There's some brand names of these, Advil, Motrin, Aleve. Those are all the same type of category of an anti-inflammatory pain. Topical medications that can be used both over the counter and prescription. And the new medication as far as for pain control that we're kind of discovering is called duloxetine, or Cymbalta is the brand name. That has some emerging evidence that it can be used, especially even after surgery, for pain control. But that's something that we should have a consultation about to discuss if that's right, either with your primary care provider or myself. Would be happy to discuss that type of medication. As far as injection goes, there's a few different types of injections. Steroid injection or a cortisone injection is a type of injection which is a strong anti-inflammatory that's injected. That can be helpful for pain control. There are gel shots, or they're also known as viscosupplementation or HA or hyaluronic acid. This is a substance that we inject in the knee. It's sort of like a grease. The knee has this hyaluronic acid in it. When you have that with arthritis, it starts to decrease in the fluid. And so we inject this into the knee joint, and this kind of supplements or substitutes for the loss of that normal molecule that's in your knee. And when we do this, a lot of people can have some relief from that. Biologics, they include PRP or platelet-rich plasma or stem cell therapy. These are more investigational injections. So that we are working on right now, trying to discover what's the appropriate role for these injections and their ability to heal the knee. There are some early studies, especially on platelet-rich plasma. They're showing some good promise in mild to moderate arthritis. But that's something, again, that could be more of a consultation discussion. We can say if that's appropriate or a role for you, possibly. Physical therapy exercise is a definite improvement in function, pain relief. It strengthens the knee. It can definitely help with balance and coordination, and also staying active keeps you in a healthy, more fit body weight, which can always help with controlling pain, especially around the knee. Lifestyle modifications, again, there's exercise and weight loss is good for your overall health, but also the joints. Every pound of weight that you carry around extra is around 4 to 5 times that amount of pressure on the knee. So if you would lose the 10 pounds, even with healthy weight loss habits and techniques, you could actually decrease the amount of pressure your knee experiences around 40 to 50 pounds. So it's a pretty significant amount, even with a small amount of weight loss. There's also several braces that could be appropriate depending on your arthritis pattern that could be helpful. So, we talked about the non-operative things, then we have to look at, well, what are when surgery could potentially be indicated, what are those types of options? Well, osteotomy is classically something that has been offered for knee arthritis. This is really largely falling out of favor. There can be some very young patients that could be indicated for or needed for, but this is largely falling out of favor with the advancement in our techniques, especially with knee replacement techniques. Knee scope or arthroscopy, you may have heard of for arthritis. The evidence is really becoming pretty clear that this is not an appropriate procedure anymore for arthritis. It can be used for meniscus type tears, but again, largely has fallen out of favor as the outcome studies are saying that this is not a very good option for knee arthritis specifically. So, quote, cleaning out the knee is no longer recommended by our academy. The joint replacement surgery, partial versus total knee replacement, is also option for arthritis when it's at its end stage. So when will I know if it's time for a knee replacement, or when do I know what's time to do surgery? Well, there's no one answer to that question. We don't take things into consideration, or I don't take my patients and look at an x-ray and say, you just have to have knee replacement surgery. I want to find the treatment plan that's specific to you. I don't treat x-rays, I treat people. So I believe in a holistic approach to treatment of patients, and I want to make sure it's the right thing for you. And so some things that go along to making those decisions are, what do your x-rays look like? But also, how is it affecting you in your life? So when would that, how would you know that? Well, we're trying some non-surgical things. Maybe you've tried some injections or a knee brace. Maybe you've changed your activities. And those things, maybe they were working before and they're not working anymore. Okay, so they're becoming less effective, or you have to go less time between those injections. That might be a sign it's time to think about a knee replacement. Your friends and family might be able to clue you in. A lot of times we're not aware of ourselves and think about or can see how it's really impacting our lives. You may talk to your family and they may tell you, hey, you've been really grouchy lately. You've been kind of, biting my head off over like little things. And, I think your knee pain's really bothering you, or it's really affecting the way that you're interacting with us. Maybe you're not going around and seeing your friends or playing those cards or going to the bowling alley or going out golfing. You can't do that as much anymore. Play with your grandkids. Those are the kind of things that people talk about and say, hey, maybe it's time to start thinking about, we could get you back to that. I also talk about the mirror examination. Just, look at yourself, really think about, hey, you may notice that when you look in the mirror, it's not the same person you recognize from before. You might see more, sleep lines on your face, or you might be a little bit more cranky or tired. You just don't recognize that person that you were before. And ultimately, when it's time for knee replacement surgery, you'll know it's like, I can't take this anymore. I'm ready to be better than that. And that's when we talk about the options for surgery. That one other helpful trick that I got from my training was a pain log. So something that you can do is a little calendar test. And what you do is you take a month-by-month calendar and you write a smiley face on it or a frowny face. And that frowny face is when your knee arthritis is limiting your ability to do the things you want to do, or maybe it was just a bad day in particular with your knee. And that day, that's when you mark a frowny face. If it's a pretty good day and your knee arthritis isn't bothering you that badly, then that's when you would put a smiley face on. Now, if you look over that last month that you take of these smiley faces and your frowny faces, and you say, how many have I seen on this paper here? There's no specific number that says, okay, you're at 15 and a half or 16, now it's time for a joint replacement. But when you start to see, if you look on the calendar and you see 25 or 28 days of the month that are frowny faces, it's probably pretty clear to you that this is impacting your life significantly. If there's only 2 or 3, then maybe it's not the time to do that. So just a generalized kind of tool to get you thinking about and being mindful of yourself and your symptoms. So we've gotten to the point where it's impacting our life significantly. We've failed all different types of treatment options. Your family members supporting you, you're saying, it's time, I think we're ready. You come to that decision. And we want to do surgery and go ahead with knee replacement surgery, that you make that decision together and you say, well, what do we do? Or how do we do this? And are all our knee replacements just the same? No, of course not. So there's several different types, but particularly the 2 main ways to think about with knee replacement surgery is the total knee versus a partial knee replacement. So a total knee is when you remove all the worn bone and cartilage and we replace it with metal and plastic. Okay, this has a very long, successful history of relief of pain. But something that's kind of left out on this discussion is, well, what if the arthritis doesn't involve the whole knee joint? Well, this may be a little bit of overkill, if you will, on that. So you might be replacing more of the joint than what you need. A partial knee replacement is only in the spot where you have the arthritis. So we only remove the worn bone and cartilage at the place of the knee that has that arthritis. So you leave the ligaments that are inside your knee intact. We don't take out any of the good cartilage or bone. We just remove the part that was worn. So this is a great option for people and can offer people an alternative to total knee replacement surgically that can be very, very effective. And the recovery tends to be a little faster. So it's a nice thing to consider. So what's the right type of replacement for me? How do I know when it's, which one's right for me? Well, beyond a specific consultation and meeting with you and discussing your lifestyle and how you are, there are some surgical basic indicators or reasons why we do a partial versus a total knee replacement. So if you look on this diagram, it shows you arthritis in 2 different patterns. There's 2 main patterns that the knee will have with arthritis. It can be across the whole joint, the entire joint surface has been involved, the cartilage is worn throughout all parts of the knee. That type of knee is one that's more towards a total knee replacement. A partial knee replacement disease, the arthritis is isolated to one portion of the joint. So the remainder of the joint has good cartilage and has no involvement. So why would we throw out all that good joint space when we can only affect and we can replace the part that's worn? That's the idea behind a partial knee replacement. So a partial knee replacement takes that section of the bone and cartilage, removes it, and you place metal and plastic implant in between there, and that resurfaces essentially your knee. So instead of taking out all this good tissue and ligaments, we keep it there. Well, why does that matter? Well, these things make your knee feel more natural and normal. So every person who's had a knee replacement, a total knee replacement, they know they've had a total knee replacement. They know they have a total knee replacement for life. It feels a lot better and it does really, really well for them, especially the bone on bone all over the knee arthritis. It's a significant improvement, but you never forget that you've had a total knee replacement. The thing about the partial knee replacements, because they are only replacing the part of the joint that's worn, people will come back reporting that they forget that they've even had a knee replacement. After they recover and heal it, they actually say, hey, there's times I don't even remember that I've had that. And so they act a lot more like the hip replacements. So they feel more natural. You can do things and just go back to kind of the activities you were doing before, and maybe you don't even notice that it's there. And so it's a nice option for people. And the other thing that's great about it is that it's only a portion of the joint. So we're not removing the whole bone and cartilage around the knee. So it's a little bit less surgery. It has been shown to have fewer complications like blood clots, infection. The procedure is generally a little faster than the total knee replacement because it's a smaller amount of the joint. And the recovery tends to be faster as well. So what do you do if you can't have a partial knee replacement? Obviously, we want to, shoot for all of our options that we can. If we don't have to do a total knee replacement, let's not do a total. But what if we can't? Well, there's total knee replacement. There's no harm in doing a thing that's appropriate for that knee. If your knee has bone on bone where it's throughout the entire joint, then there is a very, very good procedure, which is called a total knee replacement. And my technique of doing a total knee replacement and the way I was trained is to use a technique called kinematic joint replacement. Now I have a whole nother webinar that's about this very specific total knee replacement technique. And you can go to my website. It has that video. We have it recorded on there, and you can reference that and pause it and stop it and replay it. And we're going to do the same thing for this partial knee. So if we were going through this a little fast for you, or you want to go back and look at the pictures, you'll be able to do that when Kelly puts it up on our website. But either way, to kind of give you a touch point on this and to at least a segue to that is that, it's not to despair. If your knee has arthritis that's bone on bone throughout the joint, you can have a very good outcome with a total knee replacement. This kinematic alignment, the philosophy is generally to reestablish the joint back to its alignment before it had arthritis. And so instead of like the conventional way of doing a knee replacement, which you may have heard or encountered with friends where they're really a lot of pain, their swelling is really bad, they're really struggling to get around. This procedure is an incredible advancement in this, and because we don't force the square peg into a round hole. So the idea and the philosophy is that every knee is not exactly the same. Some people have a natural knock knee, some people have a straight leg, and some people have more of a bow leg. So if this is the way that normal knees are without arthritis, why would we put every single knee in the same position, regardless of whether it has a bow leg or a knock knee? So the idea behind kinematic joint alignment is that we are going to restore that joint back to the position it was like before it had arthritis. So we don't force it past the point where it wants to be. And so this minimizes the need for releases surgically, it allows for less pain and faster recovery and more natural feeling knee. So overall, the take home of what I like to talk about with any patient that I have, I want to provide excellent care and compassion care for every patient that comes in. I want to improve your quality of life, and I want to get you back to doing what you love. And while I definitely perform joint replacement surgeries, I don't just do that, and I don't just look to do surgery. I try to address each patient individually and uniquely with a holistic approach. My philosophy when I do surgery is to try to respect and restore the anatomy as much as possible, use minimally invasive techniques. And many of my patients are able to go home the same day of surgery, which is called outpatient joint replacement. You get to sleep in your own bed and recover at home. So we try to restore people and get people back to doing what they love as soon as possible. So overall, I use kinematic total knee replacement, partial knee replacement. I do an anterior minimally invasive hip replacement, and I do that with a bikini skin incision, which I also have a webinar about. You can get to my website if you want further information. So I'm located at Beechwood Medical Center. Here's our address. We have an appointment down at the bottom of the screen, a number that you can call. And now if we have any questions, I'm not sure if we have any typed in, Kelly, at all yet.
I don't see any yet, no.
Okay.
It's at the bottom of your screen. If anyone is interested, there's a meeting chat feature.
Oh, I see there's one in here.
Maybe you're
So we have a question in. It says, please explain how exercise is helpful if there's no cartilage left in the knee. That's a great question. So the exercise is designed to help support the structures and strengthen the muscles and the tendons around the knee to help provide extra support, to help provide some more flexibility. As stretching out the tendons can be helpful for that, and it overall can provide a more stronger knee. Now, it will not put cartilage back on your knee. You're exactly right. There is no exercise, there's no lotion, cream, injection, incantation, pill, or prayer that puts that cartilage back on the knee. When it's bone on bone, it's over. If there's nothing left, then there is nothing there. So it doesn't put that cartilage back on there, but it can help to support the joint and provide for more balanced knee and decreased pressure of the knee, and motion of the joint can help and has been shown to provide relief. So somebody's typing in here. If you can type in instead of drawing in, that would be more effective for you, because it's gonna, if you try to write in here, it's gonna be difficult to see or read. It says the next question on here.
Yeah, there's another question about cortisone injections and how many can be used.
Okay, so cortisone injections are a anti-inflammatory type injection. It's a very strong anti-inflammatory injection. And what you're doing is you're trying to decrease the pain and swelling that can happen from arthritis. Again, it's not a cure of arthritis, but it's trying to help relieve discomfort and pain. This generally can be done safely every 3 months. Or 3 to 4 times a year is what it usually ends up being. There are some specific reasons we can't do it more frequently, or we have to do it less frequently. And there are some reasons for some patients that they could not receive a steroid injection. For those specific reasons, we'd have to have a consultation, see if it was appropriate or right for you. I have a question on here as well. It says, let's see, I have a couple here, so let me go for there. It says, one says, can you jog after a total knee replacement? Great question. After you heal the knee replacement, I have no restrictions on your activities. You may jog, you may kneel, you may do whatever that makes you happy. I don't know if you weren't a jogger before you had arthritis. I can't make people into joggers. People ask me if they can golf afterwards. It's a classic question. And I say, I don't know, can you golf before you had the arthritis? Because I don't make people into pros or anything like that. But seriously, there is no restrictions I have. Once you've healed the knee replacement, I don't have any restrictions on your activities. I see there's another question regarding to gel injections. Yes, there are several types of gel injections. They are all hyaluronic acid. There are different formulations. And it gets more specifically into the weeds of the biochemistry. They all essentially work from a very similar concept where you're substituting that hyaluronic acid, which is a normal substance in the knee joint fluid. That substance has been shown with arthritis to decrease in the amount in the knee. So the idea is to try to substitute or supplement that. Well, when you do that, that will cause that. The hope is to cause that knee to be a little bit more cushioned and supported, and maybe relieve the discomfort. It does not eliminate arthritis, but it may make your symptoms better. So there are several different types, and there are a lot of studies on those. There's not necessarily a lot of evidence saying one is more superior to other, although that's controversial. And insurance companies they have their preferred gel injections. So it gets a little bit complicated. You have to have a specific consultation to see what was the most appropriate option, especially given those factors, because they can have their own out-of-pocket expenses. Let's see. So next, let's see the question here. Are there new knee replacement joints available today? Why can't science come up with putting a sponge between the knee joints and replace the cartilage? Well, actually, the science has done that. There have been people who have tried to put knee replacement alternatives in the knee, like joint spacers. There have been several different substances that goes back into the 1800s. People were trying to put things within the knee to try to relieve the discomfort. And they fail miserably. They do very terribly. Putting something in the knee that's not well fixed does very poorly. They tend to loosen. It tends to wear into the bone more, and it causes a lot more problems than it solves. So at this point, there is no sponge or thing you can put in there that surgically that has been shown to have a good result and durable result for that. There are the knee replacement techniques that I was talking to you about, especially kinematic joint alignment is a very big paradigm shift in knee replacement surgery. There's a whole nother webinar that you can go to read or to watch and view that. And if you have other further questions, I'm happy to take time to do a personal consultation with you and to review those with you. But good question. Let's see, how long is the gel treatment effective for, and how often can you have it done? And then there's a secondary question. Well, I'll answer that after we answer this first one. So the gel treatment, the effectiveness is individual. So each person can have a different response. Generally speaking, when I've had a successful gel injection treatment or visco supplementation injection or hyaluronic acid, they're all the same thing. They all mean the same thing. It's like Coke, Pepsi, Dr. Pepper. We were just saying, giving it different names. It's all soda. So those injections can be done when they're effective every 6 months is the time frame you can have those done. I've had some patients have had some really good success with those. And then we maybe get closer to that 6 months and you start to notice the joints get a little creaky or a little uncomfortable. And we maybe do a steroid injection to help you get through that point to that next one. But those people generally are. There are people, though, with gel injections where they do not provide significant relief. And that's some more information. It's actually diagnostic. So it's telling us some information. Maybe that knee is just not ready. It's ready for the next steps. Maybe it's time to think about a surgical intervention in that patient. It's just, we have to kind of consider all things in that circumstance. The next part of the question was when will stem cell treatment be available? So stem cell treatment is currently offered. It is investigational. And by that, I mean is that this is still being studied. The specific roles and how that works is still being figured out right now. In science, we're trying to figure this out. But we do have that treatment available. It does have out-of-pocket expense, but that's something that we'd have to talk in a more specific consultation as far as to if it's appropriate or if it's a great option, and what the specifics of your clinical circumstance would make that important, because there's a few different factors. And again, as my treatment philosophy is to take a holistic approach to people, is I can't give a blanket statement as to what is best for everybody. And I try to make it more individualized. Good question, though.
And the stem cells are not covered by insurance too. I know you said it's out of pocket, but yeah, yes,
the stem cells are not covered by insurance. There is a out-of-pocket expense to them, but they could be appropriate. Just depends on the circumstance. And again, that's due to that being studied further. Are there side effects to the gel is the question I have. Gel side effects are sort of like most side effects for anything in medication or injection. They're specifically for an injection, the side effects can be some redness or swelling or some discomfort around the joints where we do the injection. Usually ice is helpful to relieve that discomfort. Extremely rarely, there are some people who have allergic reactions, but that's very uncommon and unusual of that. So I'd say the most likely side effect when people do have them is maybe some discomfort temporarily from the injection itself. And I'd say they are overall, the majority are very well tolerated. So I think we have different chat boxes here, Kelly. So are there any other
Yeah,
ones?
I don't see any in mine. I'm not, I think someone messaged me directly at one point, but I don't have any other questions.
Okay. Yeah, I'm seeing, I think I've gotten all mine on my box here. Let's see. Just want to make sure. Okay, I have another question is what company do you use for knee replacement? So the implant system and manufacturer that I'm using currently is called Medacta. They're a Swiss company, and while that's their website has a lot of information about their specific implants, and I find them to be very effective, safe, and really reliable and reproducible. And I really like their implant systems. You can look up and Google them and find their information online if you want to know more about their specific implant company itself. But sorry, Kelly?
I believe I put a link on your website. I think it's in a blog. I will,
Okay.
when I send out the recording, I can send a link to that if you want.
Oh, great. Yeah, so that would be great. You could be a good resource to that. The purpose of my lectures is not to be specific to one company or implants is a generalized discussion, but I'm happy to, we can forward that over to you, that link, or you can go to the website to probably be most appropriate to have that. And even Googling them, they have their websites available for their, and it has a lot of patient education information on there. That's really great. So they have a good resource on there. Happy to help you out if you have any questions regarding that.
I never did a lot of investigating.
So I think we have I've answered a lot of the questions on here.
Lots of questions today. It was good.
Excellent. Yeah, thank you so much for participating, for coming, for your attention and time. I really do appreciate it. If there's any other questions that are kind of a burning question, please go ahead and write it down. We can set up an individual appointment or consultation. The appointments right there, the numbers there that you can call, or you can go to the website. A lot of this, we'll make this webinar available. So if you missed part of it, or you couldn't hear something, or there was any technical issues from your side, we could absolutely get you to watch it. You can stop it, pause it, replay it. That's the great part about that. And of course, I'm happy to spend any time with you and discuss it in our office and talk to you about our different options. Again, thank you so much for your time and attention. Thank you, Kelly, for participating and helping us out with this. I think these keep getting better and better every time we do them. And we will be scheduling another webinar here to follow the topic to be determined. We will, thanks again so much for your time. Have a great rest.
Thank you.